Good morning. The only reason I'm using the microphone because it's a small room is I'm supposed to because it's recorded. So hard to use a handheld, but here we go. How are you this morning? Good. I know. It's not actually quite so cold in here today. Oh, knock on wood, right? Yesterday, it was pretty cold. Have my down jacket. I'm Pat Tritt, Patricia Tritt. I'm from Denver, and this is the world of, or staff support in the healthcare setting, sort of some current concepts. We actually have more folks signed up, so I don't know if there'll be some more people come, but I want to go ahead and get started and respect everybody's time because we're on time. So, I have, one of my many passions, I guess, is healthcare and CISM, and I've been doing CISM for a very long time. We started our team in 1985, so don't bother doing the math about how old I am, because there you go. And I've been the team coordinator for all of those years, actually until 4 years ago when I changed roles and I travel most of the time for my job now. So it's not fair to try to be a coordinator when I'm usually not there. I'm still a team member, and I'm sort of the emeritus person and that they call on. But I've also been doing quote training since we started back in the beginning. In addition to the core courses that I teach as faculty, I have 2 courses that I developed, and one is team evolution and management, because I have, again, a real passion for organizing and keeping things going, and I have a firm belief that getting a team started isn't near as hard as keeping it going, and I just see over time teams sort of wax and wane, and how we keep them energized, re-energized, and keep them going. And then the other class is the staff support in the healthcare setting, which initially, when I developed it, I called it CISM in the healthcare setting. And over time, that has sort of that evolved, and I changed it to staff support. I'm a big believer in you pick the words that work for you and for your program and that describe your program. So I think if when I work on the EMS side, fire side, we talk more about peer support. In the hospital, I talk about staff support. But I think you just have to pick the words and the framework and the program that works for you. I think, to me, always adhering to the basic principles as well. So that's why I get so interested in teaching these classes. And I've had, my background has been healthcare, employed by a hospital most of my career until the last 4 years, in addition to working in emergency care and EMS education. And I was the director of our level 1 trauma service. So I have that perspective, and then I have the emergency response perspective. So I've been very lucky to be able to have a variety of experiences. But I always tell folks, just because I've been around for a long time and have been doing this for a long time, I don't have all the answers, but I do have lots of questions. And I think we continue to evolve. And I think healthcare particularly is at a very interesting point in terms of figuring out what to do for employees and for staff. And I think there's the traditional CISM approach and CISM education and training approach. And then there's some newer approaches, relatively newer, that have come along. And how many folks heard the RISE presentation yesterday? Again, it sounds like a very well-developed program, but it also sounds to me like they're not using quite the same training model when it talks to the amount of training and so forth. And then the team, what I call it, For You team out of Missouri, who just had some awful tornadoes in Missouri. So the For You team, and then I want you to talk about your program back there from Columbus, Ohio. So there's a variety of options, and I think healthcare is trying to figure out, what to do and what works. So our objectives for today are, first, discuss staff support from employee and employer perspectives. Secondly, identify best practices in providing staff support in healthcare. Well, that would be like best practices according to Pat. You decide what your own best practices are. And then describe various barriers to providing staff support in healthcare. That's a long list. So we will touch on those. What do you think, for everybody here is probably mostly an employee, what do you think employees in healthcare expect? And this would be true of, in any organization, but we're focusing on healthcare. So what do you think employees expect from their employer in terms of providing support for them during difficult times? What do you expect as an employee? For them to be there in a time of what?
Timely fashion.
In a timely fashion. So in being there, what are you looking for? Do you think your employer ought to provide to you? Time away from the job. And actually, I think that's one of the interesting things, because sometimes the pushback of, we're not sure we want to do this because everybody's going to want to take time off, and this is really going to further impact our staffing. All right, hi, Tom. This is going to further impact our staffing. You're going to have to come to the front because, come on, Tom. Work with me here. The reality is when something impactful, whether you want to call it a crisis or impactful or whatever, when it happens, what do you think? What's your sense? Do the staff usually want to take time off, take the day off, take a couple days off, or maybe a little bit of time to regroup and get back to it, or just go back to it?
I would think I would want someone, the employer, to have someone talk with me to help me with that decision.
Yeah.
What's best.
Yeah.
Time off, or less time, or maybe different work just for the time, or see a counselor, but
right.
Somebody to help me make that decision.
So you want the employer, I'll repeat the questions as for the micro. You want the employer to have somebody to help you make those decisions about what's in your best interest. And and again, I've been doing this for a long time, that's been my experience, no matter what population I'm working with. It's not that they're like, I'm going to use this now and I want to take, 5 days off, or that's not the case. Sometimes they want acknowledgement that something really unpleasant happened, there's something that impacted them. They want acknowledgement that it did impact them, and then somebody perhaps to listen to them and to help them figure it out. I find more often than not, the staff want to get back to it when you even ask, what do you think? Because I always, in any intervention, one of the key things for me is the what's next for you. So that's what's next for you. Are you done with your shift? When do you go home? What are you going to do? When do you come back to work? I find people aren't looking to take, a long time off. But that is one thing that, is there an opportunity to do that? And one of the things I've run into lately too is, can a team, whatever you want to call your team, can they recommend or allow somebody to leave shift and take time off versus having to go through some other management approval? So that's a bit of a sticky wicket in some places. Other things you think you want from your employer, besides to know that they care and you're not just an FTE? Pardon? Support, yeah, and identification of some of the resources as well. As an employer, what do you think? How, if any of you are in a management kind of situation, as an employer, how would you see the team, having a team of some kind?
I would want some system in place where I had confidence that if something difficult did happen, that staff would come to the employer and begin the conversation.
Okay, to have something in place that you feel comfortable with, that I would, if I can add to that, that's competent and that can provide a quality level of service, right? Not just somebody who's, because in healthcare, just like everything else, the first thing is to do no harm. So we want to make sure we're not doing any harm to our employees, and probably also, to be honest, not providing any additional exposure or liability to the organization as well. So I think those are all things that we have to think about whenever we are, whenever we're thinking about, a team and developing a team, and everybody needs to be in concert with the team and what that means and what that looks like. So the team members, the management, and then if you're unionized, I think the union as well. Everybody's got to agree. This is the program. This is the direction, and this is the way we're going. So, any other thoughts about employer and employee piece? Okay. By the way, you do have the slides, which, who needs slides? You do have the slides in your packet, but there's a handout that I don't know didn't get posted. It's just my notes, but there are a couple of other attachments to it. And so if you want the handout and you want to email me, I'm happy to email it to you. It's patricia.tritt@comcast.net. The other things I have in here are a questionnaire that we use to collect some data, some information satisfaction, basically. And then also what I call a team self-assessment, which is not only just a fun thing to do, but I think it makes us think about, what are the things we have and what are the things perhaps we're missing. So,
can you tell us your email address?
yeah, and it's patricia.tritt@comcast.net. Sorry. My handwriting's not very good either, and the marker's not very bright. How many are actually in a healthcare organization of some kind? Okay. What have been your successes? If you have a program, okay, how many of you have programs? Okay. Well, what have been your successes in your programs? What are the things that you said, yes, this works for us and this works for our staff?
Training.
Training? So say more.
I'm a trainer.
Yes, you are. And you are from?
Oklahoma.
Oklahoma?
Reynolds Army Community Hospital.
Reynolds Army Community Hospital, okay.
They allow me to train reluctantly.
Ooh, reluctantly allow you to train, okay.
So we incorporate behavioral health, chaplains, fire, sometimes police.
Okay. Behavioral health, fire, chaplains, sometimes police. Now, do you, and you use obviously the ICISF model, so do you primarily do the GRIN class, or do you do individual and group separately?
Individual groups.
Individual and group separately, okay. All right. Other successes in your programs? Yes, ma'am. And this young lady is from the Columbus Children's Hospital.
So we have Stars, which are licensed mental health clinicians on staff. I'm primarily in the emergency department, so I don't really have to go a whole lot of other places. And so I think just the relationship with the staff, I was telling Susan, and if I'm there, I feel like I'm very underutilized. However, when I'm not there and something bad happens, they're literally they are greeting me at the door.
Yeah.
And so I think sometimes just having that presence and knowing that they have support is huge. And then when it's not there, they don't know what to do with themselves. So.
Yeah, all of our programs all of our contacts aren't let's schedule a time and sit down and have this individual one-on-one conversation. So for peer supporters, and I know what I hear sometimes is, I'm halfway through a conversation with somebody and I think, maybe this is a peer support contact. They're talking to me because I'm a peer supporter. And that's one of the reasons I think it's hard to collect data on your actual individual contacts, because sometimes it's just not all that clear. So your program is, do you want to say a few words about your program? And I would come back there with a mic, but it won't go that far and I don't have a lavalier.
So our program is called You Matter. We have 5 facets. We have the EAP and Matrix as one, the Stars. We do short center rounds where they usually present some sort of ethical something and how the team was able to work together through it. We do the peer support team and the critical incident stress debriefs.
Okay.
And so we have me full-time in the emergency department. We have a part-time person in the PICU, and then we just can have contingent people that fill in as needed.
Okay. So, and what's your training for your peer support team? Are they using the ICISF model, or they have their own developed training?
So we do use the ICISF.
Yeah, all those letters, yeah.
To train them to do the debriefing.
Okay.
I'm not really sure. We have a whole You Matter second victim training that we do. It's 3 hours with the team. I'm not really sure where it came from.
Okay.
But because I took it 5 years ago.
Yeah.
So,
Do you do the individual class and the group class, or what we call the GRIN class, the 3-day class?
no, are you talking about for the?
For your peer supporters, yeah.
Oh, no, it's a 3-hour.
Okay.
They come in, they get an introduction, legal comes in and talks, other people come in and talk.
Okay. Okay. Thanks. What else? Other successes in programs? Tom?
Yeah, we have a regional system in Massachusetts And what I found that the hospitals like when we go in there is that I bring healthcare workers from another hospital. So they were much more comfortable than talking to someone from in-house.
Yeah, and that's a whole other topic that you can spend a long time on, and I know I do in training, and I'm sure you do too. Let's face it, some folks are comfortable with somebody internally, and I've had folks say, I wouldn't talk to anybody outside this organization, and then I have other people who say, I'd never talk to anybody inside this organization. So that's one of the things when I work, and I've done trainings, quote, trainings for just an ICU or just an ED, for a small team, and it's always that what's the distance between the provider and the individuals receiving the service. So whole other topic, but yeah, that, and our team primarily works that way too, and we're a regional team, but I'll go play in most places I don't know anybody, and there you go. It can work both ways. As I tell people, my favorite answer to any question is it depends. So other successes that anybody wanted to mention?
Our team was kind of similar to the RISE team. We got our start almost out of the quality reviews. We had a very, very small team, but we had kind of a horrible case, and the people that were involved did get CISD and follow-ups and stuff like that. And so it was in the higher ups of the hospital. I said, well, we did have this one team, and they were so helpful for us, and they said, well, why don't we have this all over the hospital?
Yeah.
So now our team is all over the hospital, and we have, 30, we're a fairly small hospital, and so we have trainers and that actually we received an award, so they're asking us to train with other hospitals within our city, and so we're growing, and we're very proud.
Oh, good. And where are you from?
Canada.
Oh, you're from Canada. Okay, great.
We actually train our hospital.
Oh,
Up in
Calgary Children's? It was a very cold and snowy January up there. Yes, it was. I think, unfortunately, it's the nature that oftentimes it is a really bad event that happened in whatever the organization that triggers the the need or the desire to develop some kind of a team. So great. Well, thank you for sharing those. So there's lots of successes, barriers, and I don't want to dwell on barriers. So one of the things I do talk about in working with teams and team development is don't just identify your barriers, identify your strengths. What do you have going for you in the organization? And oftentimes that's a supportive administration. So always take advantage of that when you find somebody who's going to be supportive of you. So the barriers, financial or fiscal uncertainty. It's everybody needs more. Well, I shouldn't say everybody. I do know some hospitals that seem to be pretty well funded, but it really, dollars are really important these days. So administration is always going to be looking. Always, I shouldn't use those always and nevers, but is typically going to be looking for. I hate to say how can we save this money? How can we save money? But what is it going to cost us? And so, really trying to make the case, as we've heard before, about what it can save the hospital in terms of turnover and so forth. Unknown future structures. I've lived through multiple mergers and divestitures and, takeovers in healthcare, and so that can be challenging as well in the larger landscape. But then again, what are the opportunities? And I think one of the opportunities is patient safety, which is where some of these programs got started, was because of patient safety initiatives and because of medical errors. And the Second Victim Program, which I reference here a little bit later, really gave rise to how can we support our staff members when a medical error of some type does happen. And obviously, it's broader than that now in terms of what they provide services for. What are other challenges in terms of team development, do you think? Yes.
Currently, my program, the nurses aren't, the medical staff aren't using what's there. We are also a RISE, where they've highlighted it in our hospital.
Uh-huh.
And in talking to one of the RISE leaders, the specific department that I'm in, they don't call.
Yeah, the comment was they have a RISE-based program, but folks aren't using it. And that's always a good question about why. Is it the culture of the organization? Is it how information is presented? So that would really I don't know, did you heard the presentation yesterday from the gentleman from Dublin Fire Brigade and doing a survey and asking questions and asking some crafted questions about why folks aren't using the service. Do they not feel that it's needed? Are they not aware of it? Because even though it's there, trust me, it's really hard for folks when something happens. Is the management group, well oriented, educated about it? Because I find in healthcare, our calls typically come from somewhere up the food tree. It's usually middle management. It's a department director. It's a charge nurse. And they're not all nursing units in healthcare. That's the other thing I always want to emphasize, because we've done services for finance department, for medical records, all other kinds of units as well. But the majority of them are from clinical units. And the leadership changes. You have to continue to make sure that you market yourself, and I don't like the term marketing, but you have to continue to make folks aware of your existence. So I mentioned to have a questionnaire, and I'm happy to send that to folks. And it's Pat's view of the world, but I have a list of pretty much 2 pages of questions about, team operation and, does your team have a defined selection process for team members, and do you interview your candidates? Are they, what training is required of them? So again, I'm happy to send this to anybody who wants it. Makes a nice, I think, team conversation. And you can look at this and say, well, she's crazy. We don't really do that, or we don't need to do that. And that's okay, because it's really about you. And remember, this is for what I call standard CISM team, and so your team might have a little bit different complexion. But anyway, I'm happy to send that to folks in terms of assessment if you'd like. A couple of, one of my favorite, probably my very favorite program to highlight in terms of what I think is best practices is in Melbourne, in St. Vincent's Hospital. They've been around for a long time, since 1997, and they call it the STAR team, the Staff Team Action Response. I never can remember the name. I think names are important. So as teams get organized, I think it's important that you have some kind of name, acronym, something that identifies for the staff, who it is, because then it makes it easy to reference. STAR, Support Team Action Response, doesn't exactly just trip off the tongue, but the staff remember STAR, and they have pins that are stars, and folks know when they see, they wear them on their name badges, and folks know when they see the identifier that these are folks from this particular team. So they've been very, very active. They've had the same coordinator basically since the team began, and she has actually a part-time position, a 24-hour-a-week position. That's what she does, and I find that's not usual. Mostly it's in other duties is assigned to somebody. I hope that's changing, and that there's, specific job descriptions, specific positions created for this, but I think that's also changing slowly. So these are some data, and these look a little bit dated, but I got these from Jackie previously, that they did a summary. They do tracking as they go along, but this was a summary she did after 2013. So in that period of time, and they have like 5,000 employees. Actually, they probably have more than that now, but at the time they were doing this, they had about 5,000 employees. So 534 employees accessed the program, which is really a good number. One of the things that teams don't know when you get started is if people are going to use you and how often they're going to use you. And, some teams report really high utilization and others, not so much. We tend to think, those of us who've been doing this for a long time, that, groups are the way to go. But they find that the bulk of their activity is the one-on-one conversations. And you can see, they had 374 folks in groups and 160 individuals, but mostly they're the one-on-one referrals. And then diffusings and CMBs were the group intervention of choice. And they were actually only doing CISDs 3 to 4 times a year. So for a busy, urban hospital, that seems like, they're not doing many debriefings. Why do you think they might do more diffusings than debriefings? Get them before they leave. Yeah, I think it is so hard these days, different than when I worked, and we had the old traditional, 3 shifts, and now with the 12-hour shifts, folks leave and they don't, it's hard to get them back into the workplace. It's hard to make the time. It's hard to find the time. So I'm a big advocate of if you can get them before they leave the shift, even though if you're working a 12-hour shift, and this is something you're trying to do now at the end of the shift before they leave, you're just adding to the length of the time in workplace. So that's a challenge. And mobilizing staff is a challenge to get them before they leave. But you probably have a better chance of touching them as a group than if you wait, a day or 2 days or 3 days. So that's what they have found. But they also make a good use of the crisis management briefing, and I think oftentimes that's an underused event. I know when I do training and I talk about CMBs and you ask folks, give me some examples of when this would work, they just sort of sit there and look at you because they can't figure that out. So what do you think, Tom? Is that...
I use CMBs quite often in the hospitals, out of the hospital. A little different than the book teaches it.
Yeah.
Sometimes we are at the hospital for line of duty death, essentially.
Mm-hmm.
And, they talk about the 5 phases of briefing. And I start with a CMB because people just want information at that point.
Right.
So I found it very useful in a lot of ways.
Yeah, I think that sometimes we try to shoehorn people into, you need to do this, when there's been a death of an employee for whatever reason. I personally don't find to try to do a 5-phase debriefing doesn't work, because what do people need? They need to be together, they need to talk, they need to cry, they need to hug, they need to say what's happening with the family, they want information. And one of the things I try to keep in mind all the time is mostly what people want is information. So how can we facilitate that? So that's what they've been doing. And this was and you can't read all this, but this was a poster that they did in terms of the summary when they did their report. So the summary, the implementation, outcomes, a retrospective analysis. I'll show you this little graph here in a little bit. Literature review, future directions. For any team, I think it's so helpful to have a periodic assessment, to formally go, okay, what have we done over the past whatever period of time? What's worked? What hasn't worked? What do we need to do? Do we need to recruit new members? Do we need to go back and educate, our management group? Do we need to circle back with administration? What is it that we need to do? And we get so caught up in our sort of day-to-day what we're doing, oftentimes we forget to do that important part. So they went to, they did a pretty in-depth analysis. And then this was, evaluating our staff support. And these up here, this is critical incident in the blue. Personal issues, what did folks access you for? So personal issues here in the red, and then other work-related incidents are the green up here. And then you can see over here the assessment that they got back. This was definitely improved. This is somewhat improved. This has made no difference, and this was not applicable. So whatever that meant to whoever was answering these questionnaires. And then this part over here, this was for health and well-being of those who used STAR after their stressful event, and this was who didn't use STAR. And over here you can seem to see this big chunk, by a little bit, the majority, seemed to worsen, definitely worsened, not applicable, definitely improved, somewhat improved, and made no difference. So that kind of information, that kind of data is very, very helpful. I don't know about you, but I don't like answering questionnaires. I don't like doing paperwork. I don't like doing all that. But I keep emphasizing to teams, you need to collect some data. You need to get information, because even if you're in an organization where they support you today with what you're doing, I don't know about where you come from, but where I come from, administration changes pretty frequently, especially if you're in a big system where especially your CNOs, your CEOs move from facility to facility because they keep moving up in the hierarchy in the chain. The directors change. I tell folks that there was a time at our hospital Yeah, the joke was among the middle managers, when you leave on Friday, go through the kitchen to see if your name's on a cake, because things were just changing so frequently. So, and they're hard jobs. I think they're very hard jobs. I have told my colleagues who are ED directors, and that's where I spent my early nursing career, was in the emergency department. That's the hardest job there is. That's worse than being a vice president of nursing. And a VP of nursing is probably the next hardest job. But those are hard jobs, and so oftentimes there's a lot of turnover there. So you need to have data. And one of the things that I have in the packet is just a one-page questionnaire that I encourage folks. It's not a scientific survey. It's just a questionnaire, and it's really basically a satisfaction survey. And the items on it are, get to the right page here. Oops, go back one. Go back two. And we use a 4-point Likert scale. I work with Jeff Lading, who works with graduate students in research. And Jeff said, "Oh, don't give them an option for unsure or work in the middle. They either have to agree or disagree." So we used a 4-point scale, and in addition to identifying what intervention did you participate in, the first question is, how distressing was this incident for you or to you? Because if they don't identify it as distressing, then I don't expect them to say that this was terribly helpful. So to me, that's an important question. How beneficial were the services you received for this incident or event? How helpful or useful was the information you received? Because a lot of times, to me, that's what it's about. It's information. And that's information on stress. It can be any information on stress, on coping, on, I got some additional facts from, other folks about what happened. How likely are you to recommend this type of crisis support service to others? And then what suggestion do you have for improving services? And then there's places for comments as well. Yes, ma'am. Oh, good.
That's one of the things that we struggle with
Sure.
on our team is.
Good question. And as I said, I don't like doing surveys. My Terminex man who left last week left me a voicemail about what he'd done, and you'll be receiving a satisfaction survey. And please remember that if you rate anything less than a 10, that means I failed. So don't tell me how to fill out the survey, please. And I do find that folks who fill out questionnaires are either folks who are very happy or very dissatisfied, or they're very compulsive and you gave them a piece of paper or a survey monkey, or you're not going to get your certificate until you do the evaluation. So it's not like you catch all comers. And in any kind of survey, you tend to get low response rates. So not liking to do surveys, it's hard for me to ask people to do them. But and we use paper. Partly it's because of our system. If you're all internal, you could ask them. But you have to know who's in the group to be able to distribute it electronically to their email, which then doesn't feel anonymous. Or you can tell them to go on this site and fill it out, but that will further reduce your response rate. So what I do is, when we're done with either talking with an individual or group, and you're done thanking them, thank you so much for taking time today and sharing with me. We really appreciate it. We hope this was somewhat beneficial for you. Your feedback to us is very important, and I would appreciate it. We're going to leave a questionnaire with you, and I'd appreciate it in a few days if you would fill this out and send it back. Not today. I want you to have some time to think about it, but if you wouldn't mind filling this out and sending it back. If you're internal, they can put it in an inter-office envelope. You can give them a stamped, addressed envelope. So doing that, we don't get a real high return rate, but the return we get is valuable. We sometimes they'll put the date. Sometimes they won't. Sometimes they'll write down the unit or the facility or the organization. Sometimes they don't. So you can't always tie it back to a specific. So it's a little bit difficult to. It's not as meaningful it would be if you had all those identifiers, but we want folks to feel comfortable. So, and then we review those with our team when they come back. And mostly they're very positive comments. But I don't want them back today. I want them in a few days. Now, obviously, then you run the risk of they're going to forget to do them. Yes?
I think this is absolutely amazing.
Yeah.
This slide, and I think it could be so convincing. So I'm curious, 2 the health and well-being of those who didn't
Right.
use STAR? Just wondering if you know, like, same question.
Yeah.
If you get to those folks that didn't use
Yeah.
it, who are they? So, and was this like a controlled study, or was it just they were picking up statistics and they kind of did?
Yeah, and I wouldn't frame it as a study because it's not a study, it's information. So it's data, and I think they distributed this to everybody in the organization. So, yeah. And actually, I work with a CISM team in California. It's an EMS team, and they have been doing similar things in terms of surveying. They survey their team members, but then they also serve the employees in the organization. And they've just started doing that, and they're getting back some interesting information as well. And I just find so many of us in CISM, you really don't want to be bothered, and this is just another piece we don't want to do. But I will tell you that the successful programs are ones who get data and who keep it and who get it before management to keep their commitment that, yes, we will continue with this program. In the STARS in Melbourne, this is part of their hospital mission as well. And, you know, it's certainly the faith-based affiliated hospitals oftentimes have a mission coordinator, you know, whatever the title is, and other hospitals will do that too. And maybe it's, you know, whoever's in charge of patient satisfaction, because I strongly believe patient satisfaction and employee satisfaction are very much tied together. And then they now have some other complementary programs as well, and there's some related services that the director is responsible for. And if you pull up your slides, I know this is a long email address, but all you have to do is just put St. Vincent's Hospital STAR team in Google. I love Google, and it'll pull it up and get some more information from them. They've embarked, along with other healthcare organizations in Australia, on a mental health well-being strategy. It's interesting. I was part of a presentation for a group of pediatric oncologists, hematologists, the other week at their conference, and it was on physician burnout. And one of my colleagues is from UC Davis, and she's a psychologist there, and she's in charge of the well-being program, or the wellness program there. And she said she gets, you know, people push back all the time from that word wellness. And, you know, we're struggling in our organization right now developing a caregiver well-being program. And that's what we're going to call it. But people are sort of rebelling against different kind of terms these days. So that's why I say you have to figure out, you know, what you want to call it. I do think in healthcare you have the opportunity to have your programs under employee health, if that works, because it always should be framed as health and it should be framed as a benefit. We don't want individuals thinking, oh, this is about, you know, illness or mental illness, behavioral health, those kinds of things. And this is just, I think, a nice sort of depiction of what we want to do, because we always do have to think about proactive and reactive, and we've heard about that from some speakers the last couple of days. CISM sort of has a reputation of being reactive. Education's always been one of the components, but oftentimes we don't invest our time there. So we really should be really looking at, you know, promoting positive mental health, interventions when needed, you know, protection, fostering the climate. We heard some speakers talk about that culture thing as well. It's just fascinating to me as an outsider to go in and see cultures of different organizations, whether I'm working on the emergency side or working on the healthcare side. And I love it when I have a risk manager at a hospital call and ask for services for their staff because they care, or the CNO or the CEO, or I even had a CFO called one time, if you can imagine that. But, you know, but that culture of we want to take care of our staff, we want to make sure that they get what they need. So always thinking about those things. This is, and I had a conversation with Dr. Scott recently at the University of Missouri health program, and they call theirs the For You Team for Secondary Victims. And that's what your program back here, as I understand it, is based off of. And this, as I said, grew out of patient safety issues, and obviously taking care of that piece of it, but then also how to support the team. And they were established in 2009. They have this 3-tier model. They're easy to find information about as well on the internet, and all you have to do is put in the For You team, and that one will come up. They've got a number of articles that they've published. I think because patient safety has become such an issue, and in some quarters, it really started with that Johns Hopkins case that was presented yesterday, that has made healthcare organizations so much more aware of patient safety issues. And so for me, I think the vulnerability that exists is particularly when you have staff who are impacted, who not only work long hours, because personally I think 12-hour shifts aren't very safe for anybody, but so they work those long hours, they work those long shifts, and then when they're significantly impacted and not supported, your chances of sentinel events, of near misses, et cetera, really go up. So if you need a nudge, if you need I was going to say weapon, that's probably not a very good word. If you need a tool to encourage hospitals, patient safety has been, and I think will continue to be, the buzzword. And how can these programs help improve patient safety? So I think that's a huge one. This is a copy of their brochure. Again, these are things that are downloadable from the internet. One of the things, as I said, is interesting is the training piece of that is a different model, because they're doing individual peer support conversations. They're doing what they identify as debriefings and so forth, but they don't have that same required training like ICISF does. So I think it's just a matter of, if you're going to do a program, figure out what's the training that the team members need to provide effective services. With peer support teams, the thing I probably worry the most about is that when people come for those personal issues, and you saw that was certainly a percentage of what the Melbourne folks had, some of those are really tough issues. When they come to you about maybe domestic violence, substance abuse, gambling, those are tough issues that peers need to have a lot of training in. So you need to be able at least to identify those and make sure that they get an appropriate referral. So I think those are just things we'll continue to explore, and what models work and what's the best timing for them. So services, I mentioned the pre-incident or the education. I can't say enough about that. I think for team members, doing the education is how you learn the material better, how you get most comfortable with it, and so that when you're having an individual conversation or you're doing the quote teaching in a group. So pre-incident education. I really believe healthcare you have required competencies that you have to do every year, and most of them are online, and they're in HealthStream or they're in something else, and you got to do your safety training and your infection control and all of those things. There really needs to be something that they complete annually on a self-care, on stress, which could be done very easily on a computer-based kind of program. And yes, I know nobody wants to have to do one more required course, but we need to think about that, because it's not enough to hear about it once. You need to have reminders about it. And then other services are help with decision making. I know sometimes our team gets called, and maybe we didn't end up doing a group, but we did a consultative service with the CEO because of what happened in a facility, or the CNO. So helping with decision making, and then being being consultative. How to have conversations with individuals. Obviously, the ICISF and the individual course uses the SAFER model. I have a simple handout that I use also for folks who aren't going through the full training that I just call supportive conversations, and I'm happy to share that with anybody too. It's, what are the components to have a meaningful conversation with somebody, to sit down. I have another handout on things not to say, which to me is very important, so I have that one as well. Crisis management briefing, we mentioned. I think that's an underutilized tool. I think sometimes the way it's presented and the structure gets in the way, and it's really about, giving information and helping folks explore, making them aware of, what some of the potential reactions are and the stress management tools. One of my soapboxes that I get on frequently is well, all the time, is teaching to the topic. Because I think sometimes we say, well, here's the sheet, here's potential reactions, and we don't take into consideration what was this particular event. And we want to make sure that we address that event and what the psychological impact might be of that. Like violence in the workplace, for example, and the fears of safety and all of those things. So if it's not on our handout, sometimes we forget about it. Obviously, the diffusing, we talked about the debriefing. And then I also have, and I'm happy to provide this handout too, it's something I call care time. I had an experience way back, and it actually was with a group of victims advocates, big event that happened. Victims advocates were assigned to the victims, the families, the survivors for a period of time for like a year. And they needed something to continue to support them throughout that process. So what we did was we got together with them and there were about eight, usually in our group there were 8 to 10. We got together with them every 2 to 3 weeks. We had a time set up, and we would just sit down with them and sort of run through sort of an overview. You know what the ground rules are, and everything that's said here stays here. I personally don't use that word confidentiality, and we don't have time to explain why, but an attorney told me one time, don't use that word confidential because you can't guarantee it, but everything that's said here stays here. So what's happened since the last time we met? There have been some other things that have come up. What have you been doing to take care of yourself? What are you going to commit to do before you leave here today? So we did these sessions that usually lasted about an hour. It gave them a safe place to get together, to share. And they found that to be very helpful. We had the same team members who went back each time. And I think that a similar kind of thing is possible in healthcare and units, where either on a scheduled basis or on an episodic basis, they could get together to say, maybe not talk about specific incidents, but just sort of the overall, general things that have happened. Not like you're going to, quote, debrief a specific event, though I suppose it could go there. But I think there's an opportunity that perhaps we're missing to give folks an opportunity to get together for support and for some ventilation, for support, reminders about taking care of themselves. And to me, our whole process is about how to help people help themselves. It's not anything, I don't have anything magic to say, but it's how can I mobilize the individual or mobilize the group to access their either internal resources or their coworkers, their external resources. So I have that one as well. And then sometimes I just think time out. One of the things we need to advocate with managers is when there's been an event that's had a big impact, allow staff to have a timeout. And that may be 10 minutes, it may be half an hour, maybe time away from the unit. Explore with them. Can they finish the shift? Are they okay to stay? But so much of it is just that acknowledgement that this had the potential to have a big impact. But not overplaying it, not making everything, have a big impact. It's just for this particular one. Would you do you need some time out? And I know that can be very difficult with staffing, and lack of staffing, but we need to find some ways. Other programs were touched on, Code Lavender. Does anybody do Code Lavender? And how does that received in your facility?
We're getting ready to build a giant behavioral health pavilion, and we have a huge disconnect between our acute crisis team that responds to the code, we call it Code Violet, and our
What is
security.
Code Lavender?
Oh, what's Code Lavender? Oh, tell them.
So it's usually an
It's all about lavender.
aggressive patient, or possibly a parent, or maybe a mental health patient who needs additional support. They're not able to calm down. So, but they come from different backgrounds, because a lot of our security are ex-military, and they think of everything as a potential threat. And
Yeah.
we're like, what do we need to do to keep this person calm and not flip out? And so there's a huge disconnect with them, because they're thinking safety, and they're like, why are you getting this kid Play-Doh to chuck at our head?
So what happens when the Code Lavender team comes, and who's on the Code Lavender team?
So in our emergency department, we try to limit who responds because we don't want a huge huddle of people watching.
Good plan.
So our security team, the charge nurse, our ACR team, and then if we need extra people, we can call people in, but they're not to respond unless they've been asked to come.
Okay. And it will typically, with a Code Lavender, there's a cart. There is lavender involved, and they'll have, tea, cookies. Some of them will use a wristband, It's the idea is to let other staff members know that, there's been a stressful event. And in a way, it's sort of a timeout kind of thing, and just a time to acknowledge that there's been a, particularly challenging event. And it could be, the death of an infant after a delivery. I mean, it can be a whole variety of things. I had one nurse from Boulder, and those of you who know Boulder know that's a bit of a touchy-feely place, but we was doing a class there, and she was a charge nurse in ICU, and the Code Lavender team had arrived, and somebody's, given her lavender to smell, and she's like, "I get out of here." And she said, but it helped. And I was able to just take a minute and to calm down. I was talking to a group not long ago, and they said, well, we have it, but they may not show up for like 4 hours or, and so it felt like it was too delayed. So I think that's very much a cultural thing. Is that something that's going to be accepted and work well? But you can Google Code Lavender too and see what various facilities are doing to implement that program. Swartz rounds are popular in hospitals. Sounds like you have Swartz rounds as well too, where it's multidisciplinary team. Folks get together depending on the organization, the situation. There can be a lot of folks. It's an opportunity for some ventilation to talk about their responses to what happened. So that is another option. And then the second, victim support. One of the conversations I had with Dr. Scott last week was, how does your staff respond to the concept of victim, second victim? And I get where they're coming from because something occurred and the staff is victimized in a secondary way. But I also find so many people don't want to be identified as victims, so what term do you use? And she said, well, interestingly, and they did publish an article which she sent me, is, what is the appropriate term? So that's another thing going forward, how do you identify those folks? I'm very cautious about calling anybody a victim. If it's somebody who's directly impacted, like they were in a disaster, I talk about them as being survivors rather than victims, because there's something powerless about being a victim. So I think, again, that's further, still in discussion. That's for further identification. So, but I did just, in our last minutes, want to touch on some other things that I think we tend to neglect in healthcare sometimes. And that's the importance of, one of them is the importance of humor and positive emotions. It's very easy in intense situations, and caregiving and hospitals have become such intense places since I know when I first started in the nursing profession, because so many things are now outpatients instead of inpatients, et cetera, so acuity's high. And sometimes we forget about, humor, positive humor, not some of that really dark humor that we use sometimes, but positive humor, and how it can boost the immune system. So taking time to be able, for some camaraderie, some time to laugh. And obviously, other physiologic measures like our blood pressure and our circulation, and how humor can help with those things. And I know one of the speakers mentioned yesterday about, humor and laughter, helps relax the blood vessels and increase flow of oxygen to the muscles. I always tell folks, one of my favorite stress reduction when it's been a difficult week or whatever is to watch Shrek again, because that makes me laugh, and I really enjoy doing that. And so this was a study, Canadian researchers, 300 hours observing and interviewing intensive and palliative care staff, and how humor played an essential role in promoting team relationships as well, and adds a human dimension to care support provided to seriously ill patients and families. Obviously has to be used wisely. Teamwork is another one, and folks say, wow, I mean, of course we have teamwork in our organization because that's what we do, but how can we continue to improve our teamwork and our feelings of being a team as opposed to be individuals who are doing our job? So teamwork is huge, and you can see the citation up there. It plays an important role in causation and prevention of adverse effects. It's one of the reasons drills and practice sessions, simulations, scenarios all help reduce the stress and help increase our effectiveness and really our competence. Perceptions of teamwork are associated with staff well-being, and you know that when you feel like you're really working well together as a team, it makes you feel much more positive, even if you're working in really intense, really difficult situations. Identified patterns of communication, coordination, and leadership that support effective teamwork. So, from the Journal of Advanced Nursing, urgent need to prevent or reduce buildup of acute and chronic job strain. And obviously, healthcare, behavioral health, they're built for acute and chronic job strain. And effective teamwork, particularly impeded by acute emotional strain, because when you're feeling it, it's really hard to connect with your coworkers and your team members in such an effective way. And then resilience, I think, folks, we've heard a lot about resilience. To me, that's another one of my soapboxes that I'm on. I think we need to figure out how to help build and enhance resilience. I'm particularly on a mission to make that happen in our paramedic education programs. I think also in nursing and social work and all of our others, it's how do we increase resilience? And Glenn Schroeder is my favorite person to talk on resilience. Glenn's got a couple of books out there, and I really encourage folks to get some of those and read them. But it's also interesting. So many things can be controversial. So here is where's that other article I had? So this article I just received last week from somebody, and it was in a psychiatric online journal, and it's written by two psychiatrists who say, resilience is a political concept with political origins designed to promote acquiescence to the status quo. Whoa, that's an interesting statement. And I told you I went to that conference with on hematology and oncology, and it was for physicians, fellows, and residents. And there was such a feeling, it was called burnout, but there was such a feeling that the majority of the issues are caused by the organization and the structure as opposed to the events that happen to them. So sort of a big schism in my mind about, and absolutely our healthcare system, electronic records, all of that contribute to it. But, where's the balance? There are organizational fixes that need to happen, but we also need to take care of staff when there's individual events that happened and to help build resilience. So very interesting field these days. That's all I have to say. So, and these are just, again, some of my key elements in terms of resilience and why I think it's just so important. So, but resilience is a process, and it's an outcome, and it's something that we have to work on every day. And again, organizational and managerial practices can be powerful antidotes to adverse post-traumatic reactions. So, and those are just all the things in resilience that we all know about. So there's your code. What are some additional things in our last 2 minutes? Anything else that anybody wants to add to healthcare and how to help employees? Yes, sir.
In our pre-incident education, in a really health setting, I'm on a CISM team. We try to introduce humor into the education department because then that spills over.
Yeah.
And we're actually trying to do the service.
Yeah, he's saying in a pre-incident education, try to introduce humor because that spills over. I'm a huge believer in humor. I think it's not only how we survive, how we enjoy life, and how we thrive. And obviously, it has to be appropriate humor. And if anybody's been in any of my other longer classes and see some of my cartoons, some people have said I was sick, but I always do try to use humor appropriately. So. Other thoughts or concepts in terms of healthcare and helping your staff and others? Yes, ma'am.
I think there's a culture of who signed up for this.
Oh, yeah.
This expectation that, like, well, of course your job is stressful. Like, you're an ICU nurse. Like,
Sure.
Of course your job is this, that you work 12-hour shifts. Like, so if people, like, if healthcare staff feel that they're stressed, they almost like invalidated themselves. And then
Yeah.
it's like echoed in the culture of like, like this is just what we do. Like, and I think like acknowledging that like it doesn't have to be that way. Like you're allowed to feel the impact
Right.
of things that happen is really important.
Yeah, the comment is the culture of you signed up for this. And we see that in emergency services as well. It's the, if you can't stand the heat, get out of the kitchen, and this is what it's like. And in healthcare, if I start the sentence, nurses do what? Most people can finish it with eat their young. We think oftentimes about the hazing and things that have historically have happened in emergency services, but honestly, I think healthcare can be just as bad, if not more brutal sometimes. And I think there's a variety of reasons for that. It's like I have trouble surviving the shift myself. I really don't have time for you. I can't help you too. So there's a variety of factors that go into that. And I wish I had a magic bullet for how you could change that system, how you could change that culture. Yeah, and it really takes leadership from the top to be able to say, no, this is important, and these are difficult, challenging, situations, and we're all human, and things do get to us, and that's okay. And it takes not only the upper leadership, that middle leadership, because upper leadership can be in support, but the middle manager layer is not, and you just lose it. I find because when we get called, whoever that management layer was is very supportive because they called us. But what you don't know is when you don't get called from certain units or agencies, what's the culture like there? So it is a process we all need to continue to work on, and we're looking for best practices. So when you know of those, please feel free to let me know. So we're at the end of our time. I'm going to let you go. Thank you very much for being here. Yes, sir?
How many pages was your handout? Because I just got 7, it's on the 7 pages.
Do you actually got the handout?
Well, I got 7 pages handout. How long is
That
it?
is 7 pages.
Okay, so it's on the app now.
It's on the app. Oh, good. Because before it was just the slides. But I'm happy to, provide any other information folks need. So good luck going to your next session. Thank you very much.